The one you store.
Good morning, good evening, everyone. We'll give it a couple of minutes, a few minutes for people to join, and then we will start on the clock. Thanks for joining.
Mm. We'll wait for a few minutes, 7 on the dot.
So Ruben raised their hand. I don't know if it's by mistake, perhaps. Okay. So welcome, everyone. Good morning, good afternoon, good evening, depending on your time zone. Today we have our speaker, Mr. Arjit Baghwala. Arjit is a brachytherapy guru joining us from Texas today, and he will be teaching us about HDR brachytherapy commissioning, source treatment planning systems, and commissioning of source treatment planning system and applicators. Moderating the session today. Usually, these sessions have been moderated in the past by me and Arjit, our speaker, but today we have a new staff. We have Afua joining me from Seattle to moderate the session.
Somebody had to step in for Arjit, so I was happy to do that. Yeah.
I'm so happy that you did too, and it's definitely worth it. So, it's the same format. So before I start, I just want to say that Medical Physics for World Benefit has new team, right, for their executives. However, we're keeping the same format. So thanks for joining us today in the first webinar of this year, 2026. Happy New Year, everyone. The format is the presenter will present for 45 minutes, RG. After that, that will be followed by 5 minutes of questions and answers. Please put your questions either in the chat box or the Q&A box, and we will will attend to them towards the end of the session. After the presentation, we will come back for final comments and thanks. Following this session, we will send out multiple choice questions. So pay attention to Arjit's talk because the answers will be there in the talk probably. If you answer the MCQs and send them back to us, then we can give you also certificate of attendance. This webinar, like the others, is being recorded. It will be posted online. There's an MPWB YouTube channel. You should find it there, and we'll share it with the community. So let's talk a little bit about our speaker before we start. Arjit, first of all, before I say anything, is a dear friend, extremely supportive to all his medical physics fellows, and very dedicated for patient care. Arjit is a senior radiation physicist and lead for brachytherapy at Houston Methodist Hospital in Texas. He's nationally and internationally recognized for his expertise in brachytherapy. And as a matter of fact, he will be in Dubai next month presenting at the Astro meeting. So stay tuned for that. He serves also as faculty for the American Brachytherapy Society, including the 2025 annual meeting. Arjit is a board certified physicist by the American Board of Radiology, and he's also recently become a fellow. We celebrated that of the AAPM. Huge achievement. He's actively engaged in professional service, including serving as past president of the Southwest chapter of the AAPM. He has also contributed to national education and clinical practice initiatives, including and not limited to organizing and leading ABR mock exams. So if you're preparing for ABR Part 3, also stay tuned. He runs them, what is it, twice a year? Those mock exams? Twice a year.
Twice.
Yes. And it's huge effort, but very plausible effort. He's known for his collaborative leadership, commitment to clinical excellence, dedication to advancing high quality, patient-centered radiation oncology care, a great father. I don't know how many hours a day he has. And without further ado, I'll give the screen now to Arjit. Welcome all.
Thank you. Thank you so much. Also, since Afua is here, we can all welcome our new president of the Medical Physics World Benefit too. Can you see my screen? Yeah.
Well, you couldn't share the spotlight
No.
alone. You had to extend it always. Things are
But yeah, no, thank you so much. Thank you, Sarah, again. I'll try and make this, a little bit more educational. Of course, when making these slides, the imposter syndrome always thinks that, oh, this is information that everyone knows. But I have benefited a lot when making these slides or when listening to similar lectures. And I hope, the take-home message, everyone picks up something new that they can implement in their clinic, or if you're starting a Brachy program in your clinic. But yeah, my name is Arjit Baghwala. I work at the Houston Methodist Hospital in Houston, Texas. So today we'll go through a bunch of topics today, getting to know your HDR source, recommendations and standards that are mentioned within the AAPM guidelines, the IAEA and ISTRO, HDR source commissioning. What does a clinical physicist do? Treatment planning system commissioning. And of course, you have to know your applicators. So what is brachytherapy? Brachytherapy is a Greek word that means short, as in the distance between the source and the target. So as long as you can place your radioactive source in or near the tumor site with a higher dose rate, we can do high dose rate brachytherapy and spare the nearby organs at risk due to the sharp dose fall off, primarily due to the inverse square um, behavior captured in the geometry function. And while the radial dose function accounts for the scatter and attenuation that provides a secondary modulation of a dose with distance, typically when I talk to the patients, before the treatment. I usually tell them that it's, you can imagine a half a cm source welded to the tip of a wire, and the wire is what goes inside the applicator and delivers the treatment. Um, and it's a higher dose rate, so your treatment times are relatively a lot quicker compared to low dose rate. And once you start a brachy program, the options are plenty, interstitial, intracavitary, surface, intravascular, the more creative your radiation oncologist is, the more creative the treatment planning or the brachytherapy in your clinic can get. These are just some images from what we have done in the past over here. But, of course, I'll be mentioning uh, guidelines and stuff that is mentioned within the AAPM, but I know that we have a lot of attendees today from all over the world. So these are three very good practical resources that every brachy clinic should have. These two are by the IAEA. And then the last document over here is by ISTRO, a practical guide to quality control of brachytherapy equipment. Lots of good information is provided in all these three documents. So, within the AAPM, it is important to know the source that you will be using, because we are all familiar. And if you're not, I would highly recommend for the attendees to, read these two documents, the AAPM TG43 and the AAPM Report 229. The AAPM TG43 talks about the general brachy-dose calculation formalism and required parameters that applies to both low and high energy photon emitting sources. However, between AAPM and ISTRO, unlike published reference quality dosimetry dataset for low energy brachytherapy sources, there is not much for high energy your radioactive sources. So therefore, the AAPM brachytherapy subcommittee formed a high energy brachytherapy source dosimetry working group to focus on the photon emitting brachytherapy sources with average energy higher than 50 keV. TG43 and for the 43 update provides us the basic calculation methodology. The first is your 2D formalism, and let me just run, yeah. So basically it's your dose rate, which is equal to the air coma strength multiplied by your dose rate constant, your geometry function, the radial dose function, and the anisotropy function, where your R denotes the distance in centimeters from the center of the active source to the point of interest. And the R0 is the reference distance, which is specified to be 1 cm. And your theta denotes the polar angle specified by the point of interest. And the PR theta is relative to the source longitudinal axis. The reference angle, theta 0, defines the source transverse plane and is specified to be 90 degrees. So it takes into account the line source approximation. The 1D formalism simplifies the localization procedures by eliminating the need to determine the orientation of the source longitudinal axis, and it goes after the point source approximation. But honestly, we could have a whole new lecture on TG43. But with the interest of time, I'll move on. But again, I would highly recommend for the trainees who are listening to this webinar or attending to please, look at TG43, the update document, and understand the basic calculation mechanism behind in the report. As far as the AAPM report 229, the tasks of this report were to compile a list of high-energy brachytherapy source dosimetry sources commonly used in North America and Europe, develop dosimetry prerequisite for routine clinical use of those sources similar to the low-energy ones, develop an extension of TG43 dose calculation formalism, provide a consensus data set for sources using currently dose calculation formulas, perform review of existing clinical sources, source strength calibration requirements, and recommendations of high energy brachytherapy sources, and provide brachytherapy source registry for web-based access to these high energy brachytherapy source dosimetry data. They do mention these three sources in the document, but majority in what is used is the iridium and cobalt for our purpose in the remote afterloader for HDR brachytherapy. So, just to reintroduce the previous slides and simplify it a little bit, we have iridium 192, which is quite common in North America. That is used for HDR brachytherapy. And then there's also cobalt 60 afterloader, a source that's used in the Saginova afterloader. And you can notice over here the nominal activity of the iridium is quite high compared to cobalt. However, the air comer rate for the cobalt is a lot higher. And, so that sort of takes into account with the dose rate for the treatment when you compare both cobalt 60 and the iridium 192. Now with the new Bravos and I believe even with the Flexitron afterloader, the maximum installable activity for your radioactive source can go as high as 15 curies. So for clinics that do a lot of brachytherapy or anticipate doing a lot of brachytherapy, this is really beneficial. For clinics that, cannot do constant source exchanges that is required by Iridium 192, where typically the source exchange is done every 3 months. Cobalt 60 comes in handy because of the half-life over here, 5 years. So a source exchange is required, every 4 years or so. So what does the consensus data look like? In the case of, the Cobalt 60 source, you can see the source design encapsulation consists of the active core of 0.6 millimeter diameter, 3.5 millimeter length source, and the active core is covered by a cylindrical stainless steel with a 1 millimeter outer diameter of the cable. And, the document also provides your geometrical factors and the other factors that the authors have, spent a whole lot of time collecting this data. Similarly, for the variant sources, you can see over here the source design encapsulation consists of 2.34 millimeter diameter and 2.5 millimeter long cylinders with semi-spherical ends, and the radioactive materials is uniformly distributed in these two pellets. Encapsulation again extends 1 millimeter beyond the distal end of the active core. And similar, you can see the data that's provided in AAPM report 229. The take-home message for this is HDR source commissioning is not easy. So, you can't just get a high dose rate radioactive source and start using it clinically. There's a lot more that goes behind it, as you can see in the report. And it's typically not ideal or possible for a regular clinic to be able to, collect all that data. So utilize the data that's collected, and provided. And there are other ways to perform your treatment planning system QA, and we will talk about that in the next few slides. But, that's the take-home message when it comes to your HDR source commissioning. Typically, in your in your treatment planning system, you will see how your radioactive source will be imported by either the vendor at the time of installation or even the physicist can do it. But all this data is imported, and then as a physicist, it's important where you at least double check these numbers, make sure it aligns with what is provided in the report, such as the AAPM report 229. And irrespective of the source that your clinic uses, once received from the manufacturer, every institution should follow guidelines by the ISRO or like AAPM TG56 that is recommended. As you can see in the ISRO booklet number 8, um, every institution practicing brachytherapy must have a system for measuring your source strength with calibration traceability for all source models used in its practice. This is taken from the Brachytherapy Source Calibration Manual, distributed by the company CDOS, and it says the exact same thing. Every institution shall have a system for measuring the source strength with secondary traceability. So, specification of source strength. AAPM report TG32 back in 1987 first introduced the air coma strength, which is the quantity of radiation emanating from a source, to be expressed as air coma strength. The AAPM TG43, the update, came up with a new definition where the air coma strength is the air coma rate in vacuum, and due to photons of energy greater than delta at a distance d multiplied by the square of the distance. The qualifications in vacuum means that the measurement should be corrected for photon attenuation and scattering in air and any other medium interposed between the source and the detector, as well as the photon scattering from any nearby objects, including the wall, floor, and ceilings. It also introduced the energy cutoff uh, to exclude low energy or contaminant photons. And it's similar to the reference air coma rate, which is the term used in Europe, defined at 1 meter. So what, sorry. So what do you need when doing a source exchange? So you need a well chamber that is calibrated every 2 years. You need an electrometer also that is also calibrated every 2 years, a temperature pressure barometer, transfer tube connecting the well chamber to the afterloader, a connector to connect with the afterloader turret, servometer, and GAF chromic film. And in the previous slide where I showed those resources by the IAEA, the Appendix 11 actually has this nice table that talks about the devices that you need for your brachytherapy program. Now, in the ISRO document, they also talk about clinics that can use a chamber with volume more than 0.6 cc. And they meant at this famous paper by uh, G- that talks about the 7-step method by Getch. So, we won't go through that, but I have these two resources mentioned here. Of course, the ISRO document is here, where if you do not have the well chamber, uh, I would highly recommend uh, going through these two documents for the whole setup and how to do your measurements. But for your well type chamber, it's typically a reentrant well type chamber that is almost approximating a 4-pi geometry. And it's, are typically aluminum walled, argon filled, and pressurized to improve ionization efficiency and signal stability. Their response depends strongly on source position, source length, and the photon energy. This is, typically you'll find this well chamber in clinics that do brachytherapy. So prior to the source being delivered, you will receive a letter that talks about the delivery information from the manufacturer. The document will have the source serial number, the shipping date, and the expected arrival date. And in our case, we also get to know the expected date of the source to be when the source will be at 10 curies, the nominal activity. Uh, an advice will be to reach out to your machine engineer around the time you expect to do a source exchange, because often there are chances where this letter may not reach your inbox for some reason, and you do not want the source to be delivered at a different department within your hospital without you being aware. So as soon as you start and anticipating within the first half-life of your source, reach out to your engineer who will have access to at what point should we expect our source to be delivered, and they can reach out to people who are responsible for sending these notifications to you or to your RSO. It's the source is typically delivered in a bucket. Looks something like this, um, and as soon as you receive it, within 3 hours of delivery, it is recommended for the physicist to do a survey of the bucket. Uh, because the source is not in liquid form and is sealed and encapsulated, you don't necessarily have to do a leak test. I know, like in our clinic, we do it. Also, it gives our residents a practice of going through the steps, and but yeah, you do have to get your surface readings and your readings at 1 meter. The bucket will have the delivery papers, which with the source serial number that you as the physicist should check um, with the email that was sent to you. So over here you can see those are the papers, and as soon as you take it out, you should compare the source serial number with the letter that you received, you know, couple days prior to the delivery of the source. So now engineer performs the source exchange. Once they're done with their part, now what? You know, there's document to equipment information. There's calibration date, serial number of the source. There's position verification that needs to be done. You have to test all your interlocks. There's source strength verification, source linearity, and of course your timer accuracy. And then survey around your vault and also around the afterloader. And then you create a decay table of your source. So on the day of the source exchange, the engineer will have a source certificate that they will hand over to you. And in that document that talks about the day the source was manufactured and more importantly, you'll see the air comer rate that is provided, which will come in handy for when we do our source verification. I do also want to plug in the MPPG 13A Part A guideline document that talks about, you know, the different tests that you need to do. The part B is more clinical about different types of treatments that, again, you can look at it and it has a lot of helpful tips and also the frequency of the test and the tolerance levels that are provided. So, you have your equipment information, you put in your source calibration date, the source calibration time, um, your electrometer well chamber serial numbers. Make sure that the calibration was done within 2 years of you actually using it. You need to do your pressure temperature correction. The reason why I said GAF chromic film, you can do your position verification test using the film also. We have a PermaDoc Phantom where we insert this film and we deliver the source at a known distance. And once the treatment's done, you can then see where your actual dwell times. We keep a distance of 2 cm, and each dwell position gets about 3 to 4 seconds, and that gives you a nice image. And you can then actually measure the distance between the center of each dwell position, and that should match your what you do that should match what you intend to deliver. The other now, at least with the Bravos, they also have a cam scale device that does your position verification test at 150 cm, 120 cm, and 90 cm. I know the Electa afterloader also has a ruler, and you can do a visual check of your position verification test. So this is very important to do, especially before the engineer heads out, leaves after the source exchange. Then you do your interlock test. You need to make sure that uh, while the source is at a dwell position, and you test out your interlock buttons, the source goes back to the safe in the afterloader. So, you have your interrupt button, you have the opening the door, um, and then you can turn your key in the not the off position, but uh, and then yeah, so and then of course your emergency main emergency button. So all these four interlocks should ensure that the source goes back to its to the safe if pressed, because you can only mimic these scenarios and hope you don't have to use it during a treatment. The emergency button interlock is pretty much where you will be asked to actually go back and you can sort of restart your treatment at the point from where you press the emergency button. So that's a little bit different than the other three interlocks. This is what your source holder looks like that goes inside the well chamber. So you insert the end that is closed, that's open, but they're closed inside the source holder, while this end is where you can add that connector that goes into the turret of your afterloader. And the first test you always do is sweet spot. And the sweet spot is the position in your well chamber that gives you the highest reading. And all your tests are then, all your subsequent tests will be done at the sweet spot location. So we basically use the air coma strength from the day of the source was made in the source calibration document that you saw a couple slides before. And then you calculate your air coma strength on the day of the source exchange. So you have your reading, your temperature pressure correction, your calibration factor, electrometer calibration factor, and your A-ion, P-ion factors that typically is given, provided to you. And you sort of do a back decay calc based on today's air coma strength. So for instance, in this scenario, uh, basically what we're trying to calculate is your N0. So N2 would be 42.04 equals N0 e to the minus uh, 0.693 T. T is the number of days that have elapsed from the day the source was manufactured to the day you're doing the source exchange, divided by the half-life. And finally, that number is what you do your percent error between the two air coma strength. And that is the number that should be ideally less than 3%. And as per the AAPM guidelines, if it's between 3 and 5%, you should at least investigate. Maybe there might be some sort of user error, your setup error. But if it's more than 5%, after going through your several checks and possibly even asking your neighboring clinic if they have a calibrated well chamber, if you're for sure that your readings are still more than 5%, that's when you have to report to the manufacturer. But ideally, you want this percent difference to be less than 3%. Next is the source linearity test. It basically tests to verify the electrometer readings are linearly proportional to your exposure time. It's like I mentioned, it's done at the sweet spot position, and you usually get a linear response. You have your timer constancy check. This sort of takes into account your transit dose, which is the dose delivered to a dwell position while the source travels to the position and travels back from the position. And you do that, and again, your tolerance level is about should be less than 1 second. Then you do a survey. First, you do a survey around the vault. This is, of course, with the source out. And then you do once that survey is done and the source is safely back in the afterloader, you do a survey around the afterloader also. Recently, there was an incident in one of the clinics where after treatment, they got an error notification, but for some reason, uh, they were able to clear it. And only when the physicist walked in and actually brought the survey meter near the turret. They saw that, the numbers were going quite high. So what happened was the source went all the way back to the safe, but not actually all the way back. So there was still the source outside the safe. And that's something that, no one expected. Uh, so it doesn't matter how much brachytherapy you do, there's always, you have to be alert, you have to be aware, and anything new can happen. So that's the fun of doing brachytherapy. So once, of course, you have done all your tests, you actually have to put in the source information in your treatment planning system and make sure that this data uh, actually matches the calibration certificate that was handed to you by the engineer. And then you create your decay table, which you have to then post it, near the console, hand it over to your brachytherapy team, and something that you verify um, daily during your daily QA. Next, once you have done all that, you can now commission your treatment planning system. There are plenty of resources like TG56, there's MPPG 13A, but your TPS commissioning, uh, the physicist, of course, you need to decide what algorithm you'll be using. Primarily TG43 is what is used right now in all clinics. Um, there's also the TG186, but like I said, TG43 is what is primarily being used. You have to import your source decay information into your treatment planning system. Um, this option, I know this is with Variant at least, where you get to choose between decayed and nominal. The main difference over here is if you leave it at nominal, then all your treatment plans will be done at the nominal activity of 10 curies. But if you do leave it at decayed, then this source strength, your treatment planning source strength on the day of the procedure um, should match the source decay table and the source decay that is will be on your console. So for your treatment planning system software, you have your image transfer. Um, you need to CT your an applicator. Uh, you then check the orientation. Does it match what you expect? Are there any image registration that you can do and test? Typically for brachytherapy, you have MRI, PET images, and then of course your applicator reconstruction. And in the end, there's always the end-to-end test that needs to be done. So you can see over here, typically, you import the images, and you can actually do your applicator reconstruction, and then based on the treatment plan, uh, import the plan, export the plan to your console, and then just run a test plan. For your software, you can test your contours, um, create a plan, calculate the dose, evaluate your dose as per what you expect. Does it match? And then, we have to test the communication with the afterloader. One simple test you can do within your clinic is say you did a test in this case, on the 19th of July, and you just gave a dwell time of 2 seconds. After about 73 days, uh, your dwell time should automatically double. Similarly, if your dose is 100 centigrade per fraction, if you change it to 200, your dwell time should also double. A quick test to do your TG43 calculation is if by adding a dose point, arbitrary dose point at about 1 cm, where your geometry factor and your anisotropy factor all becomes in unity. You already know your air coma strength for the day of the treatment. The dose rate constant is what you have in your system, and if you multiply those two numbers, you can sort of do a quick hand calc at that distance. At R naught is of course 1, so 1 over R square. So at that distance, your dose that you that your TPS calculates should be within plus or minus 2%. And this is a test that, ideally you should do it after every source exchange. So as mentioned, for your TPS commissioning, there's, you have to import your data model, TG43 source algorithm, source decay, image transfer reconstruction. There's image orientation, point dose calculation verification, uh, test your contours, create a plan, calculate your dose with the dose grid, uh, evaluate your DVH, dose dwell time evaluation, treatment plan, export the plan to the console, treat the plan, and then confirm dose and record and verify on your EMR that you use in your clinic. Lastly, we come to our transfer guide tubes and applicator commissioning. Gone are the days when we just stuck with just a tandem and ring or tandem and ovoid. Now there are so many, applicators that uh, have been provided to us by vendors, um, to actually target the tumor itself. And you, as a physicist, you have to be comfortable and with each and every applicator in your arsenal. You need to be able to understand and answer questions that your nurses might ask, your therapist might ask. You need to understand, which applicator is MR safe, MR compatible, which are not, so on and so forth. Of course, when you get an applicator, always visually inspect, look for cracks or missing parts. You can use your racetrack to do a length verification. Um, a very good technique is also using your LINAC with high energy electrons. If you insert X-ray markers in your applicator, you get really nice images that I'll show you in the next few slides. You have to be able to make sure that, it connects to your transfer guide tubes. And the transfer guide tube, of course, can connect to the afterloader. Um, Same thing with the transfer guide tube. When you connect your transfer guide tube to your applicator, the applicator length should be what you expect it to be. And then end-to-end test should always be done. We lay out our transfer guide tubes, we label them so that everyone's on the same page on which transfer guide tube to use. And then you have your length assessment device. This is the cylinder kit that, when one of my previous clinics, when we started a brachy program, this is what they had bought. So, you do a visual inspection. Um, you can CT the cylinder, import it to your treatment planning system, measure the diameter of each cylinder to confirm it matches what the vendor says. You can look at the 3D view. You can see for any internal damage. You can actually create your test plans and then deliver those plans also. So as I mentioned, if you tape the central channel of the cylinder to the film, and these are X-ray markers that were inserted, and using a high energy electron with about 400 to 600 MUs, you first deliver that to the film, and then you deliver your treatment plan. You sort of get a good image of your applicator and the source dwell positions. Same thing with your tandem. Typically you get tandems in 15, 30, and 60 degree and different lengths, 2, 4, and 6 cm. So same thing, tape your tandems to the film, and these are the images that you would get where you first irradiate with the X-ray marker, and then you connect your tandems to the afterloader and run a test plan, and you'll see nicely your dwell positions, and they should match. And this way you can also test the angle that the vendor says that for these tandems to be. So yeah, you can give about 4 to 8 dwell positions and 2 to 4 seconds per dwell position, and you can deliver your test plan. Same thing for the ring. Because of its curvature, it's well documented that your dwell position between your planned and was delivered, there is going to be an offset. So whenever you get the ring ring applicator, please test it out and ensure that that the dwell position that you intend to deliver is what the machine is doing. This is what the setup looks like. I have the rings taped, and these are the X-ray markers in the ring. And as soon as uh, I take the image, I then connect it to the remote afterloader and then run a test plan. This is for the needles that we had got, plastic needles that I tried to test, and this is our lipstick applicator. And this over here is we call it the bougie applicator. It's used that we use for esophageal brachytherapy. And this is your image reconstruction. And again, like I said, there are just plenty of applicators now provided by the vendors that you can have it at your arsenal and really focus on, instead of the old school point-based planning, now it's image-guided, just focusing on the tumor. So in conclusion, know your HDR source. Always do thorough QA on each and every HDR applicator that will be used in your clinic. Talk with other physicists, not just in your team, but nearby in your city, within your community. Do routine QA tests on your applicator, as each source wire is different from each other. End-to-end test, because in the end, the main goal is patient safety. It also helps if you have an amazing team of physicists, nurses, therapists, of course, your oncologists that enjoy doing brachytherapy. That's it from me. Thank you so much.
Thank you. What an incredible presentation. Sarah and I were going back and forth in a private message. Like, this was so practical. Like you displaying, like, talking about things that you've actually done. I think when presenters speak from a point of experience, the audience are able to connect, to the presentation. And this was very practical. And to be honest with you, I don't know if you were monitoring the participant. At one point we had 200 people. I know people's, connections are in and out, like myself. And so to have such an incredible attendance speaks to how much people, want to hear what you have to say. And it's being practical. It's a way that they get to connect with. So thank you for spending your morning with us. There are a lot of questions in the Q&A session, in the Q&A. And if you're ready, if you've been able to, catch your breath because you've, the last 45 minutes, you've been sharing like all your incredible, experience with us. I will go through the first three, and then I'll let Sarah go through the first three. And then I'll give a few announcements. So participants, I hope that you stay on board. And the 199 of you, we want a photo. We're very excited. So the first question that I have here now, the 21 questions. So Arjit, you might want to grab some water because your throat is gonna run dry. Okay, you're prepared and you're ready. So what type of radioactive disposal is used for HDR sources, like certification, delay, and decay? Um, Someone is asking, yeah, like how do we dispose of? I'll rephrase the question to how I understand it. And if this individual is still on the call, the two questions from him, so or here, I'll combine the two. So they're asking what type of radioactive disposal is used for HDR sources. like the certification, maybe delay of transportation of, shipment of the material to, the clinic, and then decay. And also they're asking that for dosimetric QA, they use TG43 for mechanical QA like source position tests. Which protocol is used for HDR brachytherapy? I think you had mentioned a few of them earlier on, but
Yeah.
I'll let you take this.
So for disposal, at least in my experience and what typically happens here is the source engineer, the engineer, he or she will then actually provide us with um, a return label uh, that, like a FedEx label that is then after we are done with our source exchange and the old source is back in the bucket that is sent ready to be shipped off. Um, we usually let our RSO team know, or we personally can reach out to FedEx for them to um, pick up the source. Now, I know that shipping and receiving, there is definitely training that needs to be done, that is provided by the RSO, uh, that has to be done, I believe, once every 2 to 3 years, that has to be done. So even the FedEx person who's going to come pick up the source, to my understanding, is someone that has gone through um, their the clearance. Like it cannot just be anyone. Um, that's my understanding for how it's done. For LDR, of course, it's different, and that's vendor dependent also. And if you have a hot lab, you can keep the source till it decays, but we'll stick to the HDR part. Dosimetric QA, yes, TG43 is like I said, is primarily used in all clinics right now. There are papers being published and on TG186, but yeah, TG43 is what is primarily being used by all clinics right now.
Thank you. And then I'll take the last one. I'll let Sarah take the rest. So that's the next question from an anonymous attendee. Question reads, Is a 2-year calibration for a well chamber really sufficient? Some literature suggests gradual drift over a 2-year period in accuracy of source strength verification using well chambers. At our institution, it seems that we also tend to observe these trends. Um,
That's a good question. It's of course it's a recommendation, um, but at least in the case of Iridium, you'll be doing your source exchanges every 3 months, typically based on at least hopefully every 3 months based on the contract. If you do see those gradual drifts, then and if you compare it with another neighboring site that has a calibrated chamber, um, then maybe there is something faulty with your well chamber, and you possibly do have to send it back for calibration. So you don't have to wait for 2 years, especially like I said, in the case of iridium. As far as the cobalt is concerned, um, you know, again, just because your source exchanges every 4 years does not mean that you don't run these tests based on your clinic, you know, on a annual basis or every 6 months. It's definitely ideal for you to check your devices routinely. That would be my understanding. But yeah, I agree with the drift part.
okay.
Okay, thank
Okay.
you. Do you want to go ahead, Afia? Okay. I echo what Afia has said. What a great presentation, and I think the number of the high engagement that we're seeing from questions speaks volume about that. So someone have asked. I know in North America we focus on AAPM task groups, but I someone has asked specifically about IAEA TRS 498 492. I'm not sure if they were seeking your recommendation or if they were just bringing it to your attention that other parts of the world use it too,
Like,
like use. Oh yeah, go ahead,
no,
please.
Yeah, no, thank you so much for that. I'll definitely keep that in mind.
Awesome. Okay, someone is saying to find the sweet spot, we measure current for strength and linearity we use to collect charge. What is the reason we use to collect charge? Only because in time of calibration, the equipment is calibrated based off charge. So is it to be consistent with the time of calibration? This question is by Sath B. So I guess the question is, if I'm understanding it correctly, why do you sometimes use measure the current, and why do you sometimes you measure the charge? I think that's the question.
Well, sweet spot, trying to understand.
Perhaps that's not what we actually do. Maybe they do it differently in their practice. I guess let's go back.
Yeah,
How do
I'll
you
probably
measure
have
the
to,
sweet
yeah.
spot? Let's start
Uh,
there. How do you measure the sweet spot, maybe?
so the
Or how
sweet
do you
spot,
do it?
you insert your, like I mentioned, like you insert your applicator, like the wire in the afterloader, and then you can actually, he's correct about like measuring the current, and because you're getting the highest reading
Yes.
within your within the well chamber, at that in the in your well chamber, and at that location is where you will then measure your like you run all your other tests. Um, so I'm trying to understand. So yeah, we measure the current, and that gives us thing, and then collect charge only because of the time of calibration. Uh,
I mean, for output also in external beam, we measure charge. We don't measure the current, right? Like we know over given a amount of time,
I
what
mean,
should the
no,
charge
yeah,
be, right? So
yeah,
makes sense to measure using charge. So
for
I guess, yeah,
yeah. Uh,
yeah.
I think I have an answer, but I'm also not quite sure. I probably will have to get back. Now I mentioned I see the name, but I'll definitely reach out to the
Okay.
person. Yeah.
From my dear friend, Adria. Not good seeing you here, Adria, from North Carolina. What afterloader brand gave the error where the source did not retract all the way?
Honestly, this can be done by, again, North America primarily. We have both Varian and Electa afterloaders. Um, just to be vendor neutral, I won't mention it. The take-home message is when you do survey, the room and the patient after the treatment, just survey your afterloader to the turret. That's the take-home message, irrespective of which afterloader this issue happened.
Okay. So, uh, Sasi Kumar is asking, how do you measure, I guess, the point dose, or how do you do point dose verification in brachytherapy?
So, you can create a test plan, um, and just, you can basically add a source position, um, just one dwell position, um, and then at 1 cm or 3 cm in vertical axis, you can add like your reference points, and when you calculate the dose, you'll get your isodose lines, and you can actually see what the dose at that particular point is, and that usually that should match what you expect it to be. So, like I said, because it's in Unity, your geometry factor, your anisotropy factor uh, goes away. So you're just dealing with your air coma strength, which is on the day of the plan, the verification plan, and your dose rate constant. So if you multiply those two numbers, um, you should get your that point dose that your treatment planning system shows. And in our case, like the vendor has provided us um, for certain points the expected dose to be at those points. And so we just do our manual check between those 2 points and make sure we're within plus or minus 2%.
Okay, next question is an easy one. what are the differences between intracavity and interstitial brachytherapy?
So intracavitary would be something like a tandem and ring or a cylinder, or even your Savvy for breast applicator that is going in the cavity. Interstitial is, like when you're using needles, um, going through, piercing through the skin and accessing the tumor. Um, that would be interstitial, like needles. Yeah, right. Yeah, that would be it. Yeah, or like
But
the
in terms of
esophageal.
QA,
Yeah.
yeah. But in terms of QA and all, it's same, right? Like there's no
So yeah,
difference.
so like tandem and ring QA would be same thing where you would try and film the applicator and run a test plan. For the bougie that I showed for the esophageal, um, as long as you know what the treatment process will be, like where they will implant and how we will image, I had to make sure that we were able to view our applicator correctly and have an X-ray marker that's long enough. Um, that we would use on the day of treatment. Uh, but yeah, it's the same, more or less the same process.
Makes sense. Back to Adria. What slice thickness do you CT your GYN patients at your clinic?
Uh, we
What do you
do at
use? What slice thickness do you use?
we do
Mm,
at 1 millimeter slice thickness. Yeah, and I believe
okay.
there's a recommendation to in the AAPM TG guidelines. Yeah.
Nice. Anil Singh is saying, is it required frequency to measure? Is there a required frequency to measure the source strength post source exchange?
Is it required to measure the source? Uh, I- I'm confused by the word frequency, but
Me too.
after every source exchange, the physicist uh, has to confirm um, the source calibration, through the air coma strength of your source that has been actually put in your afterloader.
That's right.
Okay.
Uh, what is the required
Yeah.
frequency to measure that? Which is basically after
Which
source
is right
exchange,
after,
right?
yeah,
Yeah,
right
yeah.
after, yeah.
Okay. How to measure dose from end-to-end plan?
So, by measure dose probably would be there is still a lot of work being done in that field, in that aspect. But when I say end to end, you know, if your treatment planning system has the typical pear-shaped, or like the tandem is, if you keep uh, 2 cm dwell positions and deliver about, 4 to 5 seconds per dwell position, you sort of see what your uh, dose, color wash would look like. Um, so you can, when you deliver that treatment plan to the film with the applicator taped to the film, that should match. That's one way to sort of measure. The other thing you can also do is, I don't know, once you deliver a known dose to your film, you can also um, scan it and see what your profile looks like. Uh, there are several ways to try and do that, but by end to end, what I mean is, as long as you can see your what the plan that you intend to deliver versus what is delivered, that's what's more important. Um, yeah.
Okay. Uh, Afia, it's 11 o'clock. Do you want to continue with the questions or
I
what do
don't
you
want
guys?
people to feel like we did not respond to them. So I think we should
Okay.
respond to the remaining questions,
Okay.
just so people have their questions answered. And we apologize, folks, if you have somewhere to be, would have loved to have like a screenshot of all of you. You can go, but the rest of you who are able to stay, we'll try and get a screenshot. So Arjit, if you're in, we're in too.
So Arjit,
Yeah. You're muted.
okay, Nay.
Yeah, sorry. Yeah. Yeah, we can go through some for sure.
Okay.
Yeah.
Okay, Afia, do you want to take it over or should I continue?
Continue, because I am lost. I know you answered Anil Singh's question, and then
Yes. Okay.
um Yeah. So there are
I'll
about
continue.
three left, RG. Oh, we
Okay.
got one in. So yeah, let's
Okay.
get through them and then yeah.
Okay. This was thanking you for the incredible presentation along with others, but he says you mentioned that a dose rate of 12 gray per hour is categorized as HDR. The question is, where do you specify that dose rate? Like I asked, where is it defined? Is it specified at the prescription point, for example, point A in cervical cancer brachytherapy or 5 millimeter from applicator surface? So where is that 12 gray per hour is defined?
I think the dose rate is more related to uh, the specific activity of the source. So by that, what I mean is like, how much radioactivity per gram is there. It's not like at a point A or 5 millimeter from the source is where you will have 12 gray per hour. Um, so, this is related to this. It boils down to the specific activity of the source, which is why iridium and cobalt is used. Um, Point A and 5 millimeter, these are prescription points where you intend to deliver your known dose.
Okay. Most of the other questions I think you've answered already, so I'm going to skip some. But this one is saying, is there a protocol to cross-calibrate a well chamber with another well chamber?
Yeah, I mean, as long as you have, you know, your correct the factors, well chamber factor and everything is been calibrated within by an accredited lab. Um, you can easily get measurements. Typically, what you can also do is before the source exchange, before your source exchange, you can sort of do a sweet spot measurement again of your current source and see, the graph should always be the same. Uh, so, your sweet spot location in theory should not change in your well chamber. But I know if we do it for LINAC, we can cross-calibrate chambers. I'm sure you can do the same thing. But typically a clinic won't have two well chambers, is my understanding.
Yes.
Yeah.
Yeah, I haven't seen a clinic with two well chambers
Yeah.
either, but maybe for regional purposes, maybe like if you have
Yeah.
especially like in low resources countries, right? So that might be useful actually.
Yes.
Um, oh man. I'm trying to choose questions that you did not already answer during your talk.
I know someone has asked,
There's a question
should,
about independent audit. I think that's a
Okay.
really good question. So somebody's asking, Evans is asking, oh, hi, Evans. He's asking that do you do any interdepartmental dosimetry audit on your brachytherapy application? Hmm.
uh, so within, do they mean like within my, like the other sites of our system or
Perhaps like
Yeah.
NRC, I guess, when they come and check, or the state. In our case,
in my
uh-huh.
case, usually it's our RSO team, they pop up out of the blue
Oh,
and
okay.
they check, all our documentation. They will check all our written directives. What do we do before our prescriptions for HDR and LDR both? That's our independent audit. And of course, you have the state that comes in also.
Okay. Um, and then we'll take, I want up to the one that was brought in at 801. So there's one at 801
Mhm.
says how should a source integrity check be carried out and how frequently should it be performed? I think you answered this one, right? You talked about this in your presentation.
Yeah,
Uh,
so once the source is exchanged, I mean, the integrity is you're doing the whole source exchange test. Uh, the frequency, um, like I said, in the case of Iridium, typically your source exchanges every 3 months. Um, so but for that particular source, you can do monthly uh, tests that would involve, you can go through the same process again. You can do a monthly QA. Um, but typically, like I said, if it's done within especially for, I guess, for cobalt, I would highly recommend doing every, 3 to 6 months. But for iridium, you can do monthly QAs for sure to just confirm the integrity. You want to make sure, your wire is not bent, the dummy wire and your active wire both.
Yeah. This individual put in, they've been raising their hands for a long time, so I want to make sure that they feel satisfied. What are the average? I don't practice brachytherapy, so I could not be part of the anybody could answer this. So Arjit is the best. Um, what are the average number of sources per case for iodine intracranial implants? Cost per source and cost per case. And is the source reusable? Um, yeah.
Well, iodine, you're looking at LDR. Uh, that's typically not in your HDR afterloader. Uh, and then, wait, what time is this? Where is this question?
So it's at 8:04. It came in at
Oh, okay,
8:04.
804. Okay.
Yeah. And they're
Yeah.
asking about the costs, per source. So if you're talking about LDR, and then the cost per case, maybe they're trying to, start one in their practice.
Yeah. So that, I guess, again, I think it just depends on your vendor and that you're getting your source from and um, where, yeah, and where you live. I could not answer that. I'm sorry. The cost,
Yeah.
yeah.
Yeah, because depending on the vendor, the cost will be different, right?
Yeah.
And every, like healthcare cost in America is different from healthcare costs like at other places. So that's not, translatable. But I hope your question was answered. So thank you everyone who stayed with us till 8:08. A lot of questions that we tried to get through all of this. On behalf of the MPWB, I'd like to thank Arjit, our speaker, Sarah, our moderator. Arjit normally, moderates the session with Sarah. So when he became the speaker, somebody had to step in, and it was an honor to step in for him. If you're on this call, we would like to hear from you. We are starting to do something different this year where it's been about 4 years of, you know, um, you guys hearing from speakers from this side of the world and from the global north. We want to hear from you what you've been doing in your clinic. For example, RJ talked about brachytherapy commissioning, application and how his clinic practices. We want to hear how you practice in your clinic. If you've commissioned a LINAC recently, if you've commissioned a sauce recently, if you've commissioned a brachytherapy, practice recently, how have you done it? We want to hear from you. We want you to teach us as well. So we're open, to hearing from you. And if you're interested, please send us an email through the MPWB, or you can send me specifically an email. I'm putting my email address here. And you can send me an email that you're interested in being a webinar speaker. Um, and we will love, love, love to hear from you. So thank you all for attending. And if you don't mind, and also Sarah put her, email, and Arjit, if you don't mind, you can put your
Yes.
email to reach out to us and we will make this happen because we want this experience to be bi-directional, and this is how we make it happen. So thanks for your attendance, and I am going to shamelessly ask you to turn on your camera.
Before we do that, Tirtharaj has been having their hands raised for a while actually. So I'm not sure if you wanted to hear. You're muted, Afia.
He put in the question about the
So
cost
we're good?
of,
Okay.
yeah, so I
Okay.
answered his
Okay.
question. Yeah,
Good, good, good,
yeah.
good. Also, before the picture, adding to what you said, Afia, Definitely thanking Arjit for the wonderful talk. Thank you so much. Thank you, Afia, for stepping up, Madam President of the new MPWB. You guys are doing great jobs. AAPM headquarters, without Lisa and her help, I don't think we would have been able to make it happen. MPW board in general, of course, Afia and others. And of course, thanks to the participants, right? Without your attendance, your engagement, this would not have been as valuable. And last but not least, for previous webinars, please scan this QR code. And this webinar also will be posted there. Stay tuned for the MCQs. It's coming your way. If you're interested in a certificate of attending this webinar, we'll send it after we receive your answers. Now we can take a picture.
Oh, before
Uh-huh.
Arjit, we had a lot of people asking if they could have access to your PowerPoint
That's
presentation.
right. That's right.
And so we had responded that if you're comfortable with it, we will share with them because we're already recording the session.
Yeah, I think that'll be
So
on our YouTube page, right? For
yeah,
MPWB. Yeah.
it will be attached, so folks, you will have access to it. Yeah. So
Not as a
how,
PDF. We typically don't attach as PDF, I think, do we?
I
No,
have to go back and check.
we don't
Yeah,
typically give hands
we
out. So
don't do
it's
that.
yeah, but we'll the video itself is there. Like you can take
Yeah.
notes and watch it and listen to it as you drive and
Okay.
whatnot.
All
Okay.
right. So how do we get everybody on screen? It's just us on screen. Maybe
Right.
this
There we
will
go.
be.
Lisa turned on her
With
camera.
webinars, we don't allow video. So you could take a picture of the participants on the side panel, but the web video is not available for webinars.
Yep, we're not doing the video. Wanted to see if we can get a photo of the participant on the screen. How do we do that? You think it's possible or not? If it's
Is it,
not, we won't sweat it.
Yeah, I don't think it is. Just on, you can open up the right-hand side but it won't show everyone at the same time. You
Yeah,
have to
it
scroll
doesn't.
down.
No, it doesn't. Don't worry, we tried.
Okay, so
Yeah,
sorry.
no, it's okay. We were just so excited to see 200 people on screen. That was like, yeah, we were very happy. But
that's
thanks,
a record.
Lisa. It is a record. Thank you so much, Lisa, for making this happen. We appreciate that. Everyone, thank you.
Before I forget, please go to the MPWB website. Check the great stuff that they are doing there. And if you're not a member, please consider joining. Thank you. Bye.
Thank you.
Bye.